and we'll be focusing on major depression and medications. And I'll give you some clue how to remember the most important. This is pharmacology at the same time, mental health. And so let's get to it. First, let me show you something. Depression. Okay, so the theory is, so when we have neurons, okay, and they communicate with each other in the brain, multiple of them. These neurons have neurotransmitters. That's how they can talk to each other in vesicles. And they release these neurotransmitters in this cleft. This is synaptic cleft. That's how they communicate. And so these neurotransmitters, when they get here, they talk to the other nerve, okay? If your body is not using these neurotransmitters, they can break it. It can break it down. And so it stays in your system, and that can control your mood. The main neurotransmitters is dopamine. Okay, we have norepinephrine and serotonin. This is what is involved in your mood stabilization, normal amount and concentration. The first S, so it's called SIGECAP. SIGECAP. So you write SIGECAP down, and then I will tell you what each letter means. So SIGECAP, the first one is sleep. Patient with depression will have sleep problem. Their sleep goes up, down, or up. So insomnia, they can't sleep at all, or they just sleep all day. So that's what will happen with the patient who's depressed. The I is interest. Their interest usually go down. So if you like to play football, go out with friends or other things, you will stop that. And G is guilt. They start having some guilt about themselves. And he talks about hopelessness. And then they feel like they don't worth anything. So worthlessness. So the E, what do you think? Well, if you can't sleep, you have lost interest, or you sleep too much, you feel guilty about life, your energy goes down. If your energy goes down, what do you think will happen? Well, you can't concentrate. You worry about everything, concentration. So this goes down. But this is the problem. You can either eat yourself up or you don't eat at all. So appetite can go up, you eat yourself because you're depressed, or you don't eat at all. The P is now you're mad at everybody, so it's called psychomotor retardation. So what it means is you get agitated easily. And the S is suicide. So that is the way you can remember symptoms of depression. The suicide is the most important aspect, and then that's what you need to pay attention, because signs of suicide is you as the next intervention. The first 2 weeks when you start the medication, you should pay attention to things that they will say. Their energy will go up. So energy goes up. So anybody start on antidepressant who start getting better right away, you should do something about it. That means they are risks of suicide. So you should be careful that you have to monitor them more frequent than usual. The other thing too you should pay attention to is when they say that or you observe them making life decision. The plans that they've already made, and all of a sudden they're completing it, like work, they're completing their work, they're giving out their property to friends. So he has a car, all of a sudden he give out his car, his house and everything. That means he's making end of life decision. If they have a project and they're finishing those projects, yes, that's a sign of suicide in these depressive patients. So You have to pay attention. That's where most of your question will lay on. If they tell you, I feel really good, well, you have to be careful and monitoring them. So now we talk about the medication. I told you because of the change in the neurotransmitted function, so like norepinephrine, dopamine, or serotonin. These neurotransmitters changes, therefore there's lack of transmission and affects the individual mood. So we have these medication for that. We said if we can increase these levels of neurotransmitters, then the nerves can talk and improve the mood of the individual. And so they are fancy names, but all it means is receptor intake inhibitor. Basically, it selectively inhibit taking up of and serotonin. And this one, serotonin preventing reuptake of norepinephrine. That's all it means. So this will increase serotonin. This may increase serotonin and norepinephrine, both reuptake. So you don't take them up and you have high level of them, and that improve the individual function. So you use SSR, that's what it means, or SNR. It doesn't matter. What you need to care of know is how to recognize them. The XSR as this last name, Xetins, Xetin, and then the other one is Lopram. There's two groups. So Xetins and the Lopram. These four, the lean, okay, these five groups are the SSRI, and this is the SNR patients. But just find a way to know them. But usually they are really they become obvious when they say it. I mean, or in the text, you see that, oh, this has a sitting at the last name, or Lopram. Don't confuse it with benzodiazepine. So Lopram, or you can go back and say talopram. You see, these are talopram. You see, talopram, these are sitins. So sitins and taloprams are SSR. And this also has a sitting last name. This doesn't follow. But basically, these are examples. You have to know at least one or two, three of them to be able to recognize them. It's a Lopram, or it's a sitting, it's a SSR. Your test, it will be based on side effect and their function. So what is their side effect? This you have to know. Okay, side effect. The number one side effect that patient is going to complain about is sexual dysfunction. So sexual dysfunction, they will be complaining about. So the drive will go down, okay? The arousal will go down, and the orgasm will go down. All of them start going down. So they will have sexual dysfunction. They will gain weight. So weight gain. Now they're feeling better and they're going to eat. So weight gain for this SSR. They may lose appetite, okay, because of this medication. And then the common side effect of most antidepressant is GI symptoms. It's non-specific, so GI symptoms. But the key symptoms is this: sexual dysfunction and weight gain. There is one that is very serious, okay? If the dose is very high, so high dose of SSR will lead to what we call serotonin syndrome. So we will talk about it later, but I need to list it. So you have to make sure you're not giving them a higher dose. That means you have too much of serotonin. Serotonin syndrome means high level of serotonin floating around, and then you go into serotonin syndrome. You have symptoms consistent with the serotonin and syndrome. So these are side effects of that medication. The key thing is, as a doctor or as a nurse, this can last for 3 months and it should get better. So if it doesn't get better after 3 months, we'll change the medication. So if the patient is complaining about sexual dysfunction, weight gain, loss appetite, GI symptoms, just tell them this is temporary, but this will go away. After 3 months, it should get better. The other thing they like to ask is education. This is all pharmacology. You got to know the pathophysiology and education of the patient. Because of the way involved in the as a neurotransmitter, it takes a long time for your body to adjust. Well, it takes like 1 to 4 weeks for their symptoms to get better. So it can take 30 days for them to have improvement. They should start getting better in 2 weeks. So when you're educating them, tell them it can last for 4 weeks. But within the first 2 weeks, they should see some improvement. Okay, because these medications take a long time to work. Well, don't stop abruptly. So don't abruptly stop the medication. That's education they can ask you. This is a classic SATA question. They shouldn't stop it abruptly. It causes insomnia. They will take it now, they feel better. If they were sleepy, now they can't sleep anymore because they have more serotonin floating around. So it causes insomnia. So what do you think? If things make you not to sleep, when would you take that medication? You don't take it at night, then you will stay up all night. So you let them take their medication in the morning, AM med. So let them take it in the morning instead of waiting in the afternoon or in the evening. Otherwise, you won't be able to and sleep. So those are the things you tell them abruptly, and they should take the medication in the morning. And suicide ideation, you the nurse, within 2 weeks, you should be looking for it, watching them like a hawk. This is my favorite because it's dangerous, but it's fun to learn about them because they are they wear medication, so they are mono. So these are monoamine oxidase inhibitor. So basically, what you means is monoamine is you talk about norepinephrine, serotonin, dopamine. They are examples of monoamine. These are like catecholamines. So norepinephrine, serotonin, and dopamine. So the medication inhibits this enzyme. You see, you can use the pathophysiology. The medication inhibits the enzyme from breaking down all these medication, all the neurotransmitters. So you have more norepinephrine available, more serotonin, more dopamine to do its effect. Unfortunately, these medications don't have a clue how to remember them. And so the board like them. They like them because there's no way you can remember them. But the way I remember them, if they give me a list of medication that look weird, one of them look weird, the name sound abnormal, I can't even pronounce it. Yes, that's it. And you can see isocarboside. I mean, I put the other trade name. They usually don't give you this. They will give you the first one. And then phenixin. And then this one, I can't even say. Tricyclic. I can't even. And then selegiline. So you see, they have weird names, and then they are dangerous medication. That's why they look weird. So if they give me option, most of the time the question will give you a clue that they're talking about MAOIs, monoamine oxidase inhibitors. So what do you have to know? Well, the same thing, side effect. And based on what you know, they are increasing norepinephrine, increasing dopamine, and decreasing serotonin. So these are all catecholamines. Well, your blood pressure is going to be high. It's going to increase your blood pressure because it's a catecholamine. Secondly, what would it? They will increase your heart rate because they are catecholamine. Okay. And then there is specific things about this medication that is they like the board like asking. Based on this, it's all based on that. And now we have side effects, right? We have side effect, increase your blood pressure, increase your heart rate. Where there's specific education you have to give this patient, education and teaching that they like to give you in SATA question or priority question. Okay, one based on one. Okay, because it increase catecholamine and it increase all the catecholamine. Well, guess what? If you go to Walmart right now and you have cold, you go and buy decongestant or some cold medication. So cold medication. Cold medications have a lot of catecholamines in it. And that's why it causes vasoconstriction to decrease and secretion, and your nose doesn't run. So decongestant. So you should avoid them. Avoid cold medication or decongestant. Easy to get it. That's why the board like to test it. And that's why you have to teach your patient. Otherwise, they will go into hypertensive crisis. They have this thing causing their blood pressure, and now they're taking something that will cold medication, increase your blood pressure. So example is like pseudoephedrine. Okay. Then the other thing they should avoid is SSR. So they should avoid SSR. They shouldn't be taking SSR or SNR. Okay. SNRI, because that will increase more of their serotonin. So they have more serotonin floating around. Taking SSR or SNR will lead to serotonin syndrome. So we'll talk about it on the next few pages. Okay, there's another medication they should avoid. It's called TCA, Tricyclic, and that one also will lead to hypertensive crisis. Avoid it completely. There's a way you can educate them. If they're taking SSRI and they want to take MOI because they're gaining weight and they don't like it, well, you have 14 days. Let them slowly wean themselves off from the SSR because you can't stop it abruptly for 14 days. And then allow the 14 days washed out. This is the washed out period. So they taper themselves off of the SSR. Then they wait for 40 weeks for a washout period so that the medication can get out of their system. Then they can take the they will begin the MAOI. So this, if you're on serotonin, well, taper yourself off, then wait 14 days, then start the MAOI. Otherwise, you will get into serotonin syndrome. There's another thing you have to tell them, which is another testable question. Okay, they should avoid certain food. Okay, that can increase their level of catecholamines and Tyramine food. Tyramine food will lead them to have hypertensive emergency. That's bad. So anybody on MOIs, this is what they like asking. Patient taking Tyramine is on Tyramine food. And there's few of them you should know. You got to memorize it. Aged cheese. Okay? They should avoid yogurt. There's few medication. They should avoid carved meat. Okay? They should avoid food that is fermented. Fermented food. They should avoid avocado. Chocolate. Red wine. And beans. So these are food they should avoid. Tyramine food. But these are the one the board like to ask. You should teach them to avoid all this medication. All this food that has Tyramine. Otherwise, they will go into hypertensive emergency. So that's that for MAOIs. Now, TCA. TCA is notoriously common. We use it so many ways. And so if I'm an examiner, that's what I'm going to ask you because it's common. We have use it all the time, and they have so many side effects. The way to so this is used for depression, but you can use it for other problem which we'll talk about. The way to remember them is triptyline. There's two groups, triptyline and pramine. Okay, imipramine. So these are the TCA, the group, and you have to recognize them. You got to picture them in your eye. As soon as you see anybody, you don't need to worry about the first name. It's triptylines. They are triptylines or pramines. These are TCA, and they can be used for depression. The problem is you can also use it for somebody with neuropathic pain. So if they have back pain due to nerve dysfunction like gabapentin, you can use it for that, neuropathic pain. So you can use it for pain management. And the common one they use is Elavil. But it's the same thing as amitriptyline. So it's common, people use it. We can also use it in bedwetting. So if your kid is over 5 years old and still peeing on himself, which is enuresis, okay? You can use these ones, desimipremim or imipremim. They can use it for that. If the kid has been more than 5 years and they've tried everything, bedwetting or enuresis, you can use TCA like imipremim or desimipremim. They have a lot of side effects. That's why I'm spending time on them. They have a lot of side effects. They have anticholinergic side effect. They have cardiac side effect. They have neuro side effect, and they are dermatological side effect. And so I call it TCA dance. So if you take TCA, watch them for dance. DACE. So the D is for dermatology, A is anticholinergic, N is neuro, C is cardiac, and E is evaluation. So evaluate them for dance. So anybody on TCA, that's my acronym. That's how I'm able to remember side effect because they like it. If you're on TCA, watch them for dance. You got to watch them for dancing. So we'll talk about each of them. What do you think? Anticholinergic. I don't even have to say too much. Which they like. Your board, I like to ask anticholinergic. You know, cholinergic is involved in your eyes, involved in salivating, involved in your bowel function, involved in your bladder. So anticholinergic means you're blocking cholinergic effect. So they cannot salivate. So decrease secretion. They will not be able to move their bowel. So constipation. Well, they will have urine output will decrease due to retention. And then their eyes, they will have like blur vision, or their pupil will be constricted. So what would you do? You can educate them. If I'm an examiner, this is what I'll ask you. What do you tell? Somebody is on amitriptyline. What do I tell them? Well, they are going to have decreased secretion from anticholinergic effect. So they can chew gum, right? Chew gum or sugar-free candy or sip on water all the time. That's my teaching. Constipation. Well, fiber, water, and don't stay in the toilet too much, and exercise. That's how you prevent constipation, not stool softener. So fiber, water, exercise, and don't stay in the toilet too much. Urinary retention, well, if they can't pee, they should call their doctor. and blurred vision. You cannot use this. If I'm an examiner, I will ask you this. Somebody with open angle, closed angle glaucoma, okay? Closed angle glaucoma. Or somebody with glaucoma, if you give them TCA, it's a problem because of the anticholinergic effect. You see what I've done? I've set the question right there for you. They also have cardiac effect. So the bad medication, they cause orthostatic hypotension, and they can also cause cardiac arrhythmia. Because of this, what teaching will you give them as a nurse? Well, get out of bed slowly, okay, when you're getting up, otherwise you're going to fall. And then a cardiac arrhythmia don't combine with any medication that causes cardiac dysfunction. And then the causes the neuro, okay, mostly neurological, they make them drowsy. Most of these antidepressants, so drowsiness and confusion. So you can see you cannot give this medication to an older patient. It's bad. All the symptoms they will be having, neurological, they will have drowsiness and confusion, anticholinergic. You can't give it to them. And the last one, dermatology, which is you can suspect is photosensitivity. And what teaching do you give somebody who taking medication that will cause photosensitivity? Wear sunscreen, wear a hat when you're going out, wear long sleeves, don't stay in the sun too long. So these are all sort of questions you should expect. How you apply. This is critical thinking question. Without not memorizing the medication, you're paying attention to what it does and what they can ask you. So photosensitivity. So those are the side effects of these medications of a TCA. You see, once again, if somebody is on a TCA, well, you should watch for their dancing. They will be dancing, drowsiness, dancing drowsiness. So they will have their side effect is dermatological, anticholinergic, and neurological, cardiac, and then observe them. So examine them for dance. If they're dancing, that means they have a side effect of TCA. That is the easy way for me to remember it. So that's my acronym to remember this medication. So what do you think? Based on what all these side effects, well, they should avoid SSR because of the cardiotoxicity of that. If they do that, if you combine TCA and SSR, they get serotonin syndrome. So they should avoid that. Okay? They should avoid TCA. They should avoid St. John Watt, which is the same. When I hear St. John Watt, I think about SSR. It's the same thing as SSR because it increases serotonin level. So you use it for depression. Some people take it for depression. Yeah, they will think, oh, okay, I'm depressed. I'll go and get St. John Watt. Then you go and see their doctor. The doctor gives them TSA and TCA or SSR, and then they go into serotonin syndrome. So St. John's, if you hear it, it means serotonin syndrome. That's the way for me to remember. You remember it. And then you shouldn't combine it with MAOIs into hypertensive urgency. So one medication, I can ask you so many things about it because it's bad. So SSRI with TCA, you get into serotonin syndrome. TCA with MOI, you become hypertensive urgency. Antidepressant combination will make this level high. Well, if I take SSR, which is going to increase my serotonin, and if I take MAOIs, which will also increase my serotonin, then I get serotonin syndrome. The same thing. If I take a SSRI, and if I combine with St. John's, what? which some people take it, is herbal medication that will also increase my serotonin. If I take SSRI, there's one medication, pay attention. This is antibiotic. So most people don't pay attention to that. Sometimes they call it Zyvas. It's antibiotic. This is vancomycin. You see, the vancomycin that we give IV, this is the oral form of vancomycin. It comes in oral form. It does the same thing. So you can use it with MRSA or VRE. So somebody who have an MRSA infection due to vancomycin and they need to take by pill, mouth, you can give them linezolid or Zyvax, but they will give you this in your test. Linezolid, that's the regular name. Why combining linezolid with SSRI will give you serotonin syndrome? This is the key. Linezolid, it has MOI properties. So linezolid do the same thing as the MOI. So that means it has MOI properties. That means it causes norepinephrine level to go up. And therefore, if you combine with the SSRI, we'll get serotonin syndrome. That tell you if you're taking linezolid because it has MOI properties, you should not eat what? Tyramines. So what is serotonin syndrome? Well, the only way I remember it is everything is on fire. So your body is on fire. It has too much serotonin. So you see, I'm using arrow. Serotonin syndrome means fire in the hole. But there is three fire that is happening. One of the fire is happening at the autonomic dysfunction. That means your body autonomic. When we say autonomy, is what control your heart rate, blood pressure. So you're going to have autonomic dysfunction. So your blood pressure goes up, your heart rate goes up, you start sweating. So diaphoresis. So these are autonomic dysfunction. Okay. And then your temperature can go up. So temp. So high temperature, sweating, blood pressure going up, heart rate going up. So you have nervous system ramping up. And how would that present? Well, you have change in mental status. So they become agitated. Okay. And they become anxious, anxiety. So those are the things. They become anxious, disoriented. So that's the nervous system. So agitated, anxiety, and disoriented. And the last one is your neuromuscular system. What does that mean? Your nerves and your muscles, your reflexes become high. And you get cluness, right? And what do you, if all the muscle is shaking, sitting there when you think about it, all your muscle is shaking, well, you'll see rigid. And this is what the word your board like, rigidity. They like when you hear somebody taking antidepressant is a SSR with rigidity, you hear the word rigidity, boom, that's buzzword. That's a buzzword. So that's priority patient. You got to see these patients. All the muscle contracting, and that is what increases your temperature. And then it releases all the chemicals, your heart rate goes up. So excessive contraction of everything. And if you're rigid, your muscle is all contracting, well, you have tremor. So how are you going to treat it? Well, bring everything down. So you have to cool them down. So cooling, give them fluid, stop the medication right away. And sometimes you can use medication, dantrolene, to help with the muscle contractions and everything to prevent it. But first thing is to cool them and give them IV fluid and let them calm down and stop the medication. If they're taking the medication, of course, stop. Whatever they're causing, taking that, is causing the problem is number one. It needs to be stopped right away. So that's serotonin syndrome right there. There's few medications. Sometimes they like to ask you, okay, on your exams, this is also antidepressant, but it do certain things. So Trazodone, they can ask you that because it's also common. It's an antidepressant, but you can use it in so many ways. It affects serotonin, so increase serotonin. And then it has this alpha receptor effect. So most alpha receptor is usually central. It affects the central nervous system, your brain. So any medication that have a alpha 1, alpha 2 receptor effect, you should know that it can affect, I would say, it affects your nervous system and usually lead to orthostatic hypotension. And then it has H1 receptor effect. So H1 receptor effect. And the H1 receptor effect. So because of this, you can use the serotonin for the depression. But since you're happy with the depression, the alpha effect is not good for you. It causes orthostatic hypotension. So you tell the patient to wake up slowly from bed, or you take it at night so that it doesn't cause orthostatic hypotension. H1, the histamine effect, most histamine medication that affect the histamine receptors are usually will make you sedated with depression. And so you can educate them, this patient, if you're taking it, make sure you get up slowly, but because it can sedate you, well, this has a good effect. If somebody has depression and they cannot sleep, so depression, depression based on the SIGECAP, if you have depression, you can your sleeping can go up or down. But if the patient has insomnia, it cannot completely sleep at all. Well, the best medication is what? Trazodone, because it can treat the hypertension, and then it can help with sedating the patient, and they can sleep. But the big thing about this is his side effect. Is this boy, priapism. And this they can ask you, patient, priority patient. So priapism is just a painful. It's very painful, sustained. You see the word painful, sustained erection greater than 2 hours. This is bad, okay? If patient taking trazodone is a male, he developed painful, sustained erection more than 2 hours. It doesn't go away. They need to go to the emergency room. It's a priority patient. Go to the ED. Or if they give you as an option, you need to go see the patient. Give you an option for patient. I'm going to see this patient. Because if you look at my B-sharp prioritization video, I talk about pain. And pain, the pain that causes pain, people have pain, but the pain that is most a priority is pain that will make you lose your life, make you lose your limb, or your eyesight. Losing your life means losing an organ. So for these patients, and losing your life is usually ischemic pain. This priapism, if you don't do anything about it, the kind of pain, sustained painful pain they will have necrosis. And they will lose their pennies. So you don't want that. I don't think you will be happy. So because of that, because to avoid the necrosis, they need to go to the emergency room right away. Stop the medication and it can be treated. So priapism is a painful, sustained erection in the patient more than 2 hours. And if that happens, it's a priority patient. Remember there's three things that can cause and priapism. So there's three things that can cause priapism. Trazodone. So just have it at the back of your mind. Sickle cell patients too. Sickle cell patients. They too, they can have ischemia too much that can lead to priapism. Or patient taking Viagra or sildenafil. So these are the three common medications that can cause priapism on a patient. They are all not really good. They are priority things you should pay attention to. So before I continue, I think it's appropriate to add this to the treatment, electroconvulsive therapy. So ECT is a testable question. This is used for somebody who has depression. He has not responded with therapy. It's really bad, severe depression. You're giving them everything and nothing has helped. Intractable. So this is intractable depression. So they usually do this to help with that. And the way they can answer this question is a SATA form because you have to know what is involved with ECT. Basically, what we're trying to do is induce seizure in the patient, and that will help. The idea is to help with the disrupt the ineffective neurotransmission, and then they will improve their mood. So you are inducing basically generalized seizure. So they will put electrodes in their head and then they will do the procedure. It's not painful. So it's not painful. So no pain. Patient would think because it's inducing seizure, they're going to have pain. It's not painful. So you got to tell them that it's not painful. However, you got to be sedated for that. So they get like anesthesia. So they get two things. Propofol. So they get propofol to help sedate them, but then they have to be relaxed. So they need a muscle relaxant. The one they usually use, I mean, whatever answer choice they give you, pharmacology, just choose if that thing is a muscle relaxant is effective. But the one they use is succinylcholine, sorry. So that's the common muscle relaxing that can paralyze you so that it will help with it, relax you so that you can do the procedure. But you can use diazepam, anything like that, anything that can relax the muscle. Okay. And then this usually they will need like 2 to 3 therapy in a week. But the patient usually forget about it. I go one and I'm done. Where 2 to 3 times a week. And then it can take 6 to 12 treatment sections. So 6 to 12 sections. So all these things, you have to educate the patient about it so that they can know what is going on. Okay. The other teaching you tell them is this is very important. They cannot have caffeine. So no coffee. They should avoid caffeine as much as possible. It affects the basically keep them really ramp up. You know, you stimulate them. You don't want that. You got to get brain function that is not overstimulated. Then so because of that, the same idea, they should avoid stimulants. No stimulant, no caffeine. So you tell them not to do that. They're going to put electrode in your head on the scalp to be able to get information. So they have to wash. You know, if females need to wash their hair so that there's no chemicals, and then it can stick and it can do the procedure. This is very important. They still continue to take their medication. Stay on your medication. So stay on your meds. And I've done teaching, education, and if I'm an examiner, those are the things I will ask you if you know anything about ECT. So no caffeine, no stimulant, wash your hair, stay, and the other previous one we talk about. So when you study and start thinking, start setting your own exams like, oh, I need to know this, I need to know this, I need to know, and there's why for all of them. Then after the procedure, so post procedure, okay. Remember, we're inducing seizure in this patient when we're sedating them. What do you think will happen after anybody who had a seizure after procedure, after normal seizure, when they wake up, they're confused, disoriented. So it's the same thing, the same care you give to somebody who had the regular seizure. So they will be disoriented, okay? They will be confused. What would you do as a nurse? You did a procedure, a patient who's confused and disoriented. What would you do? I think the appropriate thing to do is to stay with the patient. And why are you staying with them? For their safety. And as you stay with them, what are you supposed to check? Well, priority. Anybody who have a seizure, what is your priority? Number one, airway. Make sure their airway is intact. So sometimes some people will say have atropine available that will help with the secretion. So check, make sure you protect their airway, prevent aspiration and other things. And then reorient them back. Of course, you got to check their vitals, make sure they're safe, and check their mental status. So mental status. Check their mental status, make sure you reorient them, check their vitals, and your number one priority is their airway. You stay with the patient. This is something they always trick you with. They're going to have short-term memory. Short-term. You will know a short-term memory. It will come back. They will remember what happened, and you have to reorient them. So short-term memory is normal. So all you need to do is to stay with them, tell them everything, so that they know what is going on. And then that is their safety. You provide safety for these patients. This is all you need to know on the ECT, electroconvulsive therapy. But you can have education, teaching, expected finding, post-treatment. So one little thing, they can ask you a bunch of questions about it.